Welcome to the Cancer Council Victoria webinar, Clinical Consultation Skills, Communication and Optimal Cancer Care. My name is Meg Chiswell, Manager of Education and Training at Cancer Council Victoria, and I will be your host this evening. Our event will be recorded and made available on the Cancer Council Victoria website later next week. You may wish to view it again or recommend it to others. Before we begin, we would like to acknowledge the traditional owners of the land we are meeting on today. We also pay our respects to their elders, past and present, and all Aboriginal people participating today. Tonight's webinar will run for an hour and a half. The first section of the webinar will consist of presentations from our expert panellists and a panel discussion. For those of you who have not participated in a webinar before, you do not need to do anything during this time. Sit back and enjoy the presentations. You might like to have a pen and paper ready to make some notes or jot down questions that you might like to ask later in the night. Towards the end of our session, we will have our live Q&A segment with questions and answers. At this time, those attending the webinar can post a question to the panel using the question and answer function in the webinar software. During the question and answer time, the presenters will offer live responses to questions that come in from participants. We do have over 400 registrations for tonight's webinar, so I do thank you in advance for your patience during the question and answer session. We plan to gather all of the questions and answer those with common themes to forward to all webinar registrants after the event. If you have any connection problems during the webinar, please call the numbers on your screen, quoting the meeting number provided. During the webinar, some of the presentations will have links to resources or relevant websites. These links are not live in the webinar software we're using. What I mean by this is that you cannot click on them. We will provide all of the links and a list of useful resources when we email you to let you know that the webinar recording is available on our website. This document of useful resources will also be available from our website. I'm delighted to introduce our first speaker, Dr. Jonathan Silverman, who will discuss some of the evidence, tools and frameworks clinicians use for effective communication. Jonathan's full bio is available on our webinar registration page. Thank you, Jonathan.
Hey, thanks so much, Meg. I'm really delighted to be here and welcome to all the participants. What I really want to do is talk about how effective healthcare communication can improve patient outcomes. And this is very much an introduction to all the other talks you're going to hear. And I'm going to look at this generally and then we'll move on to the more specifics of communication and optimal cancer care. So really what I'm going to be talking about is the central importance of effective clinical communication to high quality healthcare. And I can't really stress this enough. This is something integral to everything we do, and communication really is the final common pathway in every decision and every aspect of medical care, whatever health professional you are. So I'm going to look at two things. First is the evidence for healthcare communication, and then secondly, I just want to look at some of the tools and frameworks which can help us put this together in a map that makes it easier for us to think about and indeed learn healthcare communication. So let's start with the evidence. And first of all, I just want to say this isn't easy. To get communication in the medical interview right takes a lot of practice and thoughtful attention. It's a really highly skilled, multifaceted professional challenge, and it's really worthy of a lot of thought so that you can really get this right. It takes a lot of practice over a lot of time. So what I'm going to be talking about now is the evidence that underpins this fundamental component of our work as health professionals. There's been research into clinical communication now for well over 40 years, and what it shows overall is that clinical communication makes for effective interviews. So the way that you communicate doesn't just affect supportiveness, which of course is a fantastic valuable outcome in itself in cancer care, but also affects how accurate you are in the discovering and giving of information, and indeed how efficient you are in the use of your valuable time. It also enhances both patient and indeed health professional satisfaction, and leads to improved health outcomes for patients in its own right. Let me just explore that a little bit more. So I put up there a shameless advert for one of our texts on this subject, which has a lot more in depth on this. But just as a summary, the research evidence shows that you can use specific communication skills, and they affect, firstly, the process of the interview, by which I mean, if you do something early on, then it affects actually what happens to the process of the interview as it proceeds. So discovering early, being able to listen early on prevents the later rising of important worries further down the line, just as you think the consultation is over. It also affects satisfaction, as I've mentioned, but it particularly impacts on recall and understanding. After all, we give a lot of information to patients, and the key is that they actually are able to remember it and understand it and take it away and use it. It also affects adherence. So once you've made a joint plan with a patient, what you really would like is that they understand it and remember it, but also wish to undertake it and do so. And the use of specific communication skills will very much impact on that and affect whether people put into plans the actions that they said that they might. But I suppose the holy grail here is outcomes. Specific communication skills can affect, firstly, decreased patient concern. So patients' concerns drop if you communicate effectively. Secondly, symptom resolution. Thirdly, physiological outcome, which I'll just come back to. And fourthly, quality of life. So physiological outcome is the holy grail of all of this, so that the way you communicate, irrespective of whatever else you do, will, for instance, lead to, in a diabetic patient, reduction in HbA1c levels, or in a hypertensive patient, a reduction in their blood pressure, or joint pain in a person with rheumatoid arthritis, irrespective of the technical parts of what you do or what you prescribe. So it's, in itself, communication is incredibly valuable in terms of thinking about patient outcomes. Now, I haven't got in any way time in this very short, brief period to talk you through a lot of this, but I want to give you one example, which I hope will show the value of what I'm talking about. And this is about patient cues. So throughout a consultation, from beginning to end, the patient is giving you cues, that is, hints of things that they'd like to discuss with you or things that they're concerned about. So a cue could be defined as a verbal or non-verbal hint suggesting an underlying emotion, which would need clarifying by the health professional. And I say hints because, in fact, that's exactly what it is. A concern is an outright expression, a cue is a hint, and what we know from the research is people are dropping cues constantly from the beginning to the end of the consultation about things that they don't overtly bring up, and for a variety of reasons they don't overtly bring it up. But if you track it through and ask patients afterwards, 80% of patients say they wanted to talk about something which they didn't bring up but had in their head during the consultation. So if you use some standard, effective, teachable communication skills, such as the ones listed here, from open questions to summarising, you will end up with the emergence of cues and concerns the more you listen. Then what happens? Well, the evidence is, so from Levinson in the States, patients give cues all the way through, but doctors miss most of them. Surprisingly here, perhaps to some, surgeons picked up more than primary care physicians. But in Zimmerman's very large systematic review in Italy, she discovered that physicians do miss most cues and actively adopt behaviours that discourage disclosure. And you can see why. perhaps if we pick up the cues, we open Pandora's box and lead to an immense amount of time spent on the interview, which we're worried about. And particularly so, because the more cues you pick up and the more listening you do, and the more open questions you ask about a cue, the more further cues will come. So if you use this set of skills, as I've mentioned, cues will arrive, and we can teach, or you can learn, a set of other skills which help pick those up. Because again, the evidence is that even if we've heard them, we're not very good at exploring. So if we explore them and use empathy and clarify and check and acknowledge, we can, in fact, allow the patient to talk about them. Pandora's box, what is the evidence that doing that will lead to longer or shorter interviews? And the answer is perhaps counterintuitive. In fact, in general practice and surgery and oncology, consultations reduced by 10%. And that is perhaps a really fantastic way of looking at this efficiency as well as accuracy and supportiveness. Cue-driven consultation, where you deliberately pick them up, shortens your time with patients and enables them to get to what they want to talk about. Now let me just change tack here. There are many difficult communication challenges in cancer care. And I've been talking about some rather specific, basic core skills. But importantly, whether it's breaking bad news or cultural diversity issues or shared decision-making, all of these difficult challenges are in fact underpinned by the same basic core skills. So it's not having to reinvent the wheel every time, but master the core skills and apply them in different circumstances. So where the process, although the issues change, the core process skills remain a secure platform for tackling each individual communication issue. Context changes, content changes, but the process skills remain the same. Now, in just a second, I'm going to show you a video. And what I'm going to do is show a very brief video from a fantastic television series in the UK called Behind Closed Doors, of real GP consultations with real patients. And in here, we're looking at a general practitioner who clearly has some of the skills listed here of picking up cues, of open questioning, and of discovering the patient's concerns. And yet there's something also missing. So let me just show the consultation and then I'll talk about it. Bear with me while we change over.
I don't know, I'm going through all kinds of negativities, you know.
About the chemotherapy?
Yeah, once I'm in there, I'm wired up, that's it, they got me.
What are you worried about? What
the agony.
You? The agony of
the agony of it. This, I know
the pain there.
I know what's coming, yeah. I already know what's coming, I can feel it. But with the chemo, I can possibly push me up to a year, maybe beyond. But a severely disabled lad, he's blind, you know. I've been his sole carer for the last 16 years.
Right.
My son, yeah.
Yeah.
And I need to prepare him because he's acquired brain damage. You know, he needs to be prepared for this one. You know, we protected him when his mum had cancer, and she died, and he was in a mess. You know, so now he's going to have no one there.
And in that short clip, you've seen a general practitioner at the coalface. And what's so interesting about that is he also talks quite movingly to camera later about the difficulty of helping patients such as this and how empathic he feels. And although he uses a lot of the skills you can see here, the one thing he doesn't use, and he doesn't use in several interviews, is empathy. He doesn't ever, at any point, apart from non-verbally, say to the man, I can really see that's a very difficult position. And I think it's that level of thinking about the skills that we use and what we can do to enable our patients to work with us in partnership that's really important. So core skills. Okay, just in the last few minutes, I want to talk about some tools and frameworks that help define and learn healthcare communication. And the first is a classic model produced in the 80s in Canada called the disease illness model. So we've all been trained in our health professional background to discover the sequence of events and the symptoms and signs, and eventually an objective diagnosis. And yet many of us haven't been trained to find this side, the patient's ideas and beliefs, concerns, expectations, how it's affecting their life, which is much more subjective and differs for every patient. And yet if we do find both, we're in a far better position when it comes to difficult explanations to really explain to patients in terms that they can understand, because we're basing it in their health belief system and their concerns and worries. And the second type of model I'm going to talk about is a structure for learning, the learners, teachers and practitioners. And the one I'm going to just talk about is the Calgary-Cambridge Guide, because it's the one that I was involved in developing about 20 years ago. And effectively, it looks at any medical interview, and this is particularly based on an intake interview in medical practice, and explores each of these particular elements, particularly the relationship and structuring, but also each of the sequential elements in the centre, so that you can break it down into objectives. You can look at, as on the right-hand side, both non-verbal approaches and rapport building, which would include empathy, and break it down into small areas. So you can take each section, work out what the basic skills are that the evidence tells us makes a difference, and again, for gathering information, the skills we've been talking about already in this presentation. And these will form the basis of every difficult challenge. I've only shown two areas here. So in conclusion, this is an evidence-based subject. It's not the art of medicine. It's the science of medicine. It's the area which we need to work on when we're working with individual human beings, with patients, so that we can effectively help them through their problems in the most accurate, efficient and supportive way. Thank you very much indeed.
Thank you, Jonathan. And just a reminder that there's the opportunity to ask questions of all of the panellists at the end of the session. So if you have questions, write them down as we go through, and we can come to these at the end. So as part of the Cancer Council Victoria team, I'll be delivering the next presentation describing the optimal care pathways, including communication elements to these. But before I do this, I'd like to make mention of EACH, which is the European Association for Communication in Healthcare. EACH is a worldwide organisation whose mission it is to promote effective evidence-based patient-centred communication between health professionals and patients. If you're interested in communication in healthcare or are just starting out, I'd suggest you have a look at the EACH website to learn some more about EACH, and if you are a communication skills teacher, to access some fantastic resources. EACH has a summer event planned next September in London, and there's details of this on the EACH website. I'd also like to mention the Victorian Cancer Clinicians Communication Program from Cancer Council Victoria. This is a program for communication skills training. It's not new and has been around for some years. So Cancer Council trains trainers that deliver their program in their own organisations. The 4-hour experiential workshops use simulated patients and small groups with a maximum of 8 participants, and this is really about learning by reflective practice. In response to feedback from participants and aligning with the principles of the flipped classroom, Cancer Council is moving towards a blended learning delivery model whereby participants are provided with online theory and reflective activities prior to attending face-to-face workshops, so that there's more time for experiential role play and skills practice. And this program is available in Victoria and in Western Australia. So with regards to the learning outcomes of the program, these are really based around reflection on your own communication skills, identification of effective approaches to contextualise scenarios, application of evidence-based frameworks, and the opportunity to develop new strategies and practice these skills. So communication along the cancer trajectory. We've heard from Jonathan about communication in general, but we know that communication is important in the cancer care trajectory with regard to participation and adoption of healthy lifestyle behaviours, engagement in screening and follow-up of screening results, dealing with diagnosis and the ability to cope with a life-threatening illness, being able to make decisions about treatment, promotion and participation of engagement in clinical trials, and the transition to survivorship and end-of-life care. Optimal care pathways is something that there has been lots of investment of energy and time into, and I'll talk about those a little bit in a moment. So Jonathan spoke a little bit about patient-centred care and the patient being central to care. The Australian Commission of Safety and Quality in Healthcare defines patient-centred care as healthcare that is respectful of and responsive to the preferences, needs and values of patients and consumers. There's strong evidence that a patient-centred focus can lead to improvements in healthcare quality and outcomes by increasing cost-effectiveness as well as patient, family and staff satisfaction. The Institute of Medicine has another definition, which is that patient-centred care is providing care that is respectful of and responsive to individual patient preferences, needs and values, and ensuring that patient values guide all clinical decisions. Epstein and colleagues discussed three core elements of patient-centred care, being consideration of patients' needs, perspectives and experience, opportunities for patients to participate in their care, and enhancement of the clinician-patient relationship which we've heard about from Jonathan. In considering patient-centred care, it's important to note that patient-centredness is not just a quality that relates to individual clinicians, but to the health system and depends on clinicians, patients and health services. And collectively, these are related in quite a complex way. Patient-centred care is therefore a quality of personal, professional and organisational relationships. Approaches to promote patient-centred care should consider patient-centredness of patients and their families, clinicians and the health system, which brings us to the optimal care pathways. I've done it. Sorry. The Victorian Department of Health commissioned Cancer Council Victoria to conduct a review of the optimal care pathways. The optimal care pathways map the journey for the cancer patient for specific tumour types, and this pathway extends from prevention and early detection, presentation, initial investigations and referral, diagnosis, staging and treatment planning, treatment and care after initial treatment and recovery, so moving into survivorship, the management of recurrent or metastatic disease and end-of-life care. The purpose of the optimal care pathways is to improve patient outcomes and promote consistent care on a standardised patient pathway. The pathways have been endorsed by the National Cancer Expert Review Group, or NCERG, Cancer Australia, Cancer Council Australia and the Australian Health Ministers Advisory Council. The OCPs, or optimal care pathways, are being implemented nationally. The optimal care pathways are aligned with key service improvement activities, including access to coordinated multidisciplinary care and supportive care, and reducing unwanted variations in practice. When considering multidisciplinary care in the optimal care pathway, this is referring to the integrated team approach to healthcare, where all relevant treatment options are considered and a collaborative individualised treatment plan is developed in partnership with patients and considering their values and preferences. Supportive care can address a wide range of needs across the continuum of care and should include and consider physical needs, psychological needs, social needs, informational needs and spiritual needs. All members of the multidisciplinary team have a role to play in the provision of supportive care. Support from family, friends, support groups and peer support, and support from organisations such as Cancer Council can all contribute to the supportive care of cancer patients. So communication with patients, as outlined in the optimal care pathways, should be individualised and in plain language. be truthful and transparent, be culturally sensitive, delivered in an appropriate setting and context, active, interactive and proactive, and should be inclusive of patients and their families. As healthcare providers, we should take responsibility for communication with patients, listening to patients and acting on information provided by and for them. We should encourage expression of individuals' needs, concerns and emotions and tailor the information to meet the needs of both patients and their families. Using interpreters when communicating with patients from culturally and linguistically diverse backgrounds is also important. We should consider the use of a question prompt list, which should be provided in advance of consultation so patients could consider which questions are relevant to them. We should consider the provision of recordings or summaries of key consultations, as these have been shown to improve patient recall and satisfaction. So the image that I'm showing here is from the website on the What to Expect guide. The What to Expect guide is the consumer guide of the optimal care pathways and has been produced on the website and also in various forms to provide patients with information about their disease. To achieve patient-centred care, patients must be able to communicate with their health professionals, revealing their needs, preferences and expectations, as we've heard quite a lot. There are some things that we can do to promote active patient communication. Active patient communication behaviours include asking questions, being able to share and relay their health story, expressing concerns and conveying fears. Stating opinions and being confident in introducing topics for discussion with their health professionals is also important. Active patient behaviours such as these allow patients' perspectives to come through and may influence clinician behaviour and decision making. The degree to which patients in cancer consultations are active participants in their consultation has been linked to their level of education and ethnicity. Cultural, social and personality factors are also at play. Evidence shows that patient education interventions aimed at increasing active communication behaviours from patients in consultations are most successful when patients believe that their participation in their care is legitimate, have some information about their health condition and treatment options, and we must consider health literacy as a barrier in the provision of information, and have the opportunities to learn specific communication strategies and behaviours to use in their interactions with clinicians. Having the education or tools providing these skills with enough time that they can again consider and implement suggestions in these is important. Culturally appropriate information is also an important consideration, and the What to Expect guides are available in different languages. So just looking again at the tools that are available for patients related to the optimal care pathways. This is an example of the What to Expect guide for breast cancer, and you can see there that on the website there is some information but also some referral to support, including community organisations such as Cancer Council. There's downloadable PDF documents that can be used to print off and help patients develop their questions. So this is an example of the full PDF guide that's available for patients, the What to Expect guide related to breast cancer. And in that, you'll note, if you have a look on the website, that there are specific things that health professionals should be discussing at the various stages with patients along the way. So it's important for us to know as health professionals that our patients are coming to us with information about what they can expect with regard to their treatment along the way. Thank you. So moving to our next speaker, Dr. Deborah Wilson is a GP in West Brunswick in a busy family practice. She's also a GP clinical educator with Health Pathways Melbourne, based at Northwest Melbourne Primary Healthcare Network. Deb's full bio is again available on our website. Thank you, Deborah.
Thank you, Meg, and thank you to Cancer Council Victoria for the opportunity, and to Jonathan too for a very entertaining first talk. As Meg said, I'm a GP in West Brunswick, so this is my everyday. I'm also a GP clinical editor with Health Pathways Melbourne, which is a web-based program originally based in Canterbury, New Zealand, and it's written by GPs and for GPs. So my presentation will focus on some of the practical approaches to communication with patients that I've found useful, particularly in translating the evidence that Jonathan spoke about, also, and Meg has introduced in terms of the optimal care pathways, translating that into a usable way in practice. Now, if you'd like to find your region for the health pathways, if you go to the healthpathwayscommunity.org website on that slide, you'll be able to find it. So I think as GPs, we have the hardest job of all. Amongst the thousands of patients that we see each year, we must determine which patients may have an early cancer, raise the issue with our patients, work out the most appropriate test, which will assist in diagnosing the cancer if present, and then give bad news to our patients. Where testing raises the possibility of cancer, we must try and organise access to biopsy and tissue diagnosis in a timely way, whilst managing the distress and uncertainty for our patients. Where cancer has not been proved, we deal with the fallout of creating unnecessary worry in our patients. When new tests such as genome mapping or celebrity diagnoses of cancer occur, we must manage the heightened anxiety that ensues. And when a friend of a patient develops cancer, we see the parents of young children with their existential worry of an early death. Amongst all the health anxiety, we as GPs must try and work out the right patient who needs the right test and at the right time. So I think it's really, really hard. So how can we make the process a little less hard and more shared? What tools may assist the communication process with our patients? I certainly don't profess to be an expert, but I have a few things that help me along the way. So I'll take you along the colorectal cancer journey as I've been working on this for Health Pathways. So step 1A, prevention. Our role in prevention and cancer screening is a strong role. We know modifying lifestyle factors can reduce the risk of cancer significantly. So how can we use evidence and resources to support our knowledge and assist communication exchange with our patients? Patients, I think, like to hear about the latest research. So using reliable resources such as the wiki.cancer.org.au, owned by Cancer Council Australia, helps to bring evidence into the consulting room to reinforce our message. Approximately 11% of colorectal cancer is associated with overweight and obesity, and is linked to more than a third of other cancers such as endometrial and esophageal cancer. Broadening the conversation to make healthy lifestyle a shared struggle helps to build reciprocity and trust with our patients. How do we maintain a healthy lifestyle whilst working long hours, sitting at a desk, managing the stress that comes along with listening to the many stories we hear every day, helps to make the experience of being human shared. This can help build knowledge of our patients' preferences too and preferred communication styles. For example, are they information avoiders or preferers? Do they need more or less information to make an informed decision? Building understanding of our patient's temperament too, such as the stoic, who in my view must be interrogated and over-investigated so that early signs are not missed, helps to extend respect within the doctor-patient relationship. General practice and primary care make important contributions to the effective delivery of cancer screening programs. Studies have shown that GP endorsement of invitations, recall and reminder systems, audit and feedback on screening lead to higher participation rates in cancer screening programs by patients. Now, we've done reasonably well in our support for cervical and breast cancer screening programs, with recalls for pap smear screening, for example, flagged within our medical software systems. But we've done not so well with promotion of the National Bowel Cancer Screening Program. Overall, the participation rate in the National Bowel Cancer Screening Program is 38.4%, and this compares with the English experience where participation rates have been as high as 61.8%. We can improve this by knowledge, active encouragement, and improving the systems in our practice. For instance, this slide from the Centre of Research Excellence in Colorectal Cancer Screening shows outcomes for screening for those at average risk of colorectal cancer. This image helps to explain to patients and to us why screening for bowel cancer is so important. The most obvious message from the slide is the importance of screening in the earlier detection of colorectal cancer, better cure rates and reduction in colorectal cancer deaths compared to no screening, as shown in the orange section in the centre. Almost triple the number of stage A cancers were detected through the National Bowel Cancer Screening Program compared with those diagnosed through symptoms. The ease of the inexpensive fecal occult blood test compared to colonoscopy, plus the significantly reduced risk of harm, makes the fecal occult blood test a much preferred test for population screening compared to colonoscopy. It's also important to discuss with patients early in the screening process the meaning of a positive test, in this case the positive fecal occult blood test, along with the reason for screening, that is detecting colorectal cancer early. A positive test in this situation doesn't mean they do have cancer, but it will mean another test. Improving systems in our practice will make support for screening programs more explicit to our patients. For example, this slide shows the age groups who will be invited to participate in the National Bowel Cancer Screening Program in 2017. By coordinating information of the targeted age groups for screening for each year across our practices, from reception waiting rooms through posters and year of birth listings to our practice nurses who are skilled in chronic disease management and our consulting rooms, we can boost participation rates significantly. Endorsing the fecal occult blood test as an evidence-based screening test and reminding targeted patients, including 49-year-olds, that they will soon receive their kit in the mail means the arrival of the test will not be a surprise, but expected, endorsed, and part of usual healthcare. So on to the next step. I've listed them as steps 1C and 2, early detection and symptoms and signs. This next slide highlights the difficulty in determining from presentation and symptoms alone which patients may have colorectal cancer and therefore need to have their path to tissue diagnosis fast-tracked. In fairness, and Peter will talk, I hope, in fairness, I think our specialist colleagues understand this challenge, but are themselves overwhelmed by demand for their expertise. With rising health anxiety amongst our patients and fear of delayed or misdiagnosis by GPs, the burden of care increases for all in the health system. So how do we find a way through this maze? We need to think of suspected cancer more in terms of likelihood through combinations of age, symptoms and signs. The adage that rectal bleeding is cancer until proven otherwise must take in other factors to determine the probability and therefore the need for fast-tracked care. This table, from large studies in the UK, estimates the probability of cancer with a combination of symptoms and signs. We can use this table with our patients to aid in discussing the likelihood that their symptoms may be due to cancer. For instance, rectal bleeding increases the possibility of cancer, but if the bleeding is recurrent and in the presence of abnormal rectal examination, the risk increases significantly. Medicine and general practice has become more cerebral in my time of practice, so explaining the need for intimate examination, such as rectal examination, has become trickier with our patients. This table helps to explain, in my view, how important physical examination, particularly rectal examination, is in determining the need for fast-tracked care. It also helps patients to understand how complex determining the possibility of cancer can be. Showing that we are taking the symptoms seriously and working within an evidence base to determine the risk of cancer for them may help to allay some fears for patients. Now, I'll introduce this slide, but I won't talk about it in depth, which is from the NICE UK guidelines, to show that fast-track care for patients with suspected cancer is a recommended goal. Facilitating a tissue diagnosis for patients with suspected cancer requires clear lines of communication and responsibility to reduce the distress for patients already overwhelmed with the possibility of cancer diagnosis. This time of active waiting is a stressful time for patients and their families, and we have a strong role in supporting our patients and their families during this time of uncertainty. Resources such as the helpline at the Cancer Council Victoria and the Cancer Pathways website that Meg introduced can offer support to patients in this time of active waiting. So I'll talk a little about the art. Jonathan's talked about the science. I think the art of communication, particularly in cancer, is hard. If I was to pen a letter to my junior self, I would say, it will be okay. You will get it wrong at times, but you will also get it right. You will disappoint patients along the way, and you will miss things, especially in the stoic. However, you will remember their faces as you learn from their stories. You will trigger strong emotions in your patients, but you will become much better at sitting with your own fears and better at finding the right words. The art of communication is magical, and you will learn something about yourself from each encounter and will work to be better. And above all, you will develop your own wisdom through kindness and respect for others and for yourself. Find a mentor, watch them closely, and you will find your way. Now, if I was to say to you as a patient, and if I saw you in my consultation room, I would say, I can't save you, I can barely save myself, but together we can find a way through. I would give you the information that you want to know by asking questions. For example, do you want to know about treatments, prognosis, outcomes or side effects? I would encourage you to participate in cancer screening for all the reasons I've outlined, but I'll respect your right to decline. If I'm giving you bad news, I will do it in person. I will make sure that I have a plan of management organised before I give you the bad news. I will try not to give you bad news before a weekend. I will give you my phone number in case you need support. I will ask you who are you going to tell when you go home and who you can call if you're having a bad day. I will see you as more than your cancer, as a person with dreams and hopes for the future. And I will continue to know you after your experience with cancer as outcomes and treatments improve at a rapid rate. So thank you again for the opportunity, and I'll hand back to Meg.
Thank you, Deborah. And just a reminder again that we'll hear some more from Deborah in our panel discussion at the end of the session and in our question and answer. We're very fortunate to have our international communication expert, Dr. Jonathan Silverman, provide us with another presentation. And this time we'll be focusing on the communication tasks in steps 3 and 4 of the optimal care pathway.
Thanks very much indeed, Meg. I'm sorry for those of you having to look at my picture on this slide yet again, but here I am. And I actually want to take on what we've just heard about from Deb and continue thinking about the next steps in the optimum care pathway. And I'm going to focus on a slightly different perspective in a way, which is many, many different health professionals are involved as the person here changes and transforms into a patient. So from somebody who didn't think of themselves as a patient, who definitely does, by the time we finish these next 2 steps, which are the diagnosis, staging and treatment planning, and then the next step, which is treatment itself. And I'm going to look particularly at the intricacies of actually the health professional and patient communication as they talk to each other. Deb mentioned that you would find your way as you went through this, as you became a health professional over many, many years. And I'm going to take a slightly different perspective on this, is sometimes we find our way and sometimes we actually need education and help in helping us get there somewhat quicker than we might do by ourselves. And also, sometimes many of us actually don't get there. There are all sorts of reasons why we get bogged down. And thinking through very carefully what the specific communication skills are and engaging in the sort of programs which the Cancer Council can put on to help health professionals communicate, I think is vital. So you could say that these 2 steps predominantly are about this element of communication, explanation and planning, that component of the Cadbury-Cambridge guide that I showed earlier. I just want to say that would be a little bit of a mistake if we thought that every time we were tackling these 2 particular elements, it only is about explanation and planning or giving information, that it starts there. In fact, no consultation ever starts there, even if the patient has come back for the results of their tests. Always there's an element of reinitiating the session, of really setting the agenda for what this consultation is about, and particularly developing rapport. Sometimes it's a patient you've not met before, particularly in a specialist clinic. Sometimes, so the building relationship in a short period of time becomes very important. Just imagine you're a patient going to see a doctor or a nurse and somebody talking through a new part of your treatment or diagnosis, and you don't know them and you don't have any rapport with that person. It's extremely difficult from both sides to get the message across. The relationship helps all aspects of giving information and indeed gathering information. And if you look at the gathering information component here, Of course, even if you're thinking of giving information, complex and difficult and hard information, there's much to know from the patient first. How are they at the moment? What's happened to them since they were last seen? What's their starting point? What have they been told so far? How have they been coping along the path where they may be in considerable uncertainty? What do they understand about what's happened to them and what might be happening to them? And indeed, what do they want to know, which might not be what you want to tell them. It might not be only what you want to tell them. And what are their concerns so that you can explain to them in relation to what they're worried about. So, again, I'm going to take this patient, perhaps, who's had rectal bleeding and might be on the pathway to discovering that they've got a colonic cancer. And the step we're looking at here is diagnosis, staging and treatment planning. And there are various tasks involved in communication here which all of us who are health professionals have to take into account. I suppose the first is the initial diagnosis of cancer with the patient, discussing it with them, and of course discussing it with their significant others. Second is explaining what's going to happen next in terms of investigation and staging once the initial diagnosis has been made. Then there's explaining the treatment planning that's going to occur, including the role of the multidisciplinary team. And fourthly, there's ensuring an interaction and coordination between everybody involved, the whole of the specialist team, general practitioners, and others involved in care. So I'll take each of those in turn and start with discussing the initial diagnosis of cancer. And this isn't clear even who is going to do this. When a patient with rectal bleeding presents to the general practitioner and they refer on to whatever the system is in your system, of course most people with rectal bleeding are not going to turn out to have cancer, and so it isn't really the GP initially who breaks the bad news that that's what they've got, but they will be part of a pathway in which perhaps at that moment the reason for referral and the reason for urgent referral has to be talked about, and the possibilities. Then you might see a colonoscopist next who might or might not be the same as the surgeon you're going to see, and who might or might not be a part of your care rather than somebody who simply is undertaking a procedure. It's not clear when to tell about the initial diagnosis. Do you wait until you've got definitive results? Do you tell it when you are seeing a tumour through the colonoscope? Or what indeed to talk about at any different stage? We don't know many times as clinicians what exactly we're dealing with, although we have our suspicions and we know up to a certain point. And it's certainly not clear what will happen after the initial diagnosis is made, because it will depend on further investigations and tests. So it's not just uncertain for the patient, but it's actually uncertain for the health professional, quite what they're saying and quite who's doing it at any one time. And so perhaps it's worth thinking of this as one of these conversations of diagnosis and talking about the initial diagnosis of cancer is one of a series of breaking bad news consultations, often where the baton is passed from one health professional to another. And I want to just spend some time now talking about breaking bad news. So breaking bad news is something that we all have to do and probably all find very hard to do. Not as hard as the patient will feel. And there are, again, two major aspects of this. One is giving difficult information, explanation and planning. And it follows the core skills of explanation and planning, which I'll talk about in a minute as we go. But also with a very heightened need to take account of the relationship. So a lot of difficult relationship building is required and attending to the patient's worries and concerns and emotions as this goes on. So it is explanation and planning in the context of high emotion. And if I just start with breaking bad news and look at some of the, I'm not going to read each one of these, but I want to just cherry pick as I go. And the first is preparation. There are many things here which are important in terms of making sure the situation is as appropriate as possible to tell somebody some particularly difficult information, such as inviting a relative or spouse to be there if possible and making sure that you're prepared and that you have enough time and you're uninterrupted. Then the second component is really being very careful about beginning the situation. Although you're about to give information, always think about what you need to find out. Check with the patient where they think they've got to. Discover what's happened since they were last seen. Calibrate in your own mind by listening how the patient is thinking and feeling and negotiating an agenda for today. And then there's the difficult task of sharing the information. And sharing the information, the set of skills that I've listed here are in fact exactly the same as you would do in any other information giving. So breaking the information down into small chunks, being careful with your pace, checking repeatedly for the patient's understanding, being careful with language, giving basic information simply and honestly, giving a warning that you're about to give information, word signposting, and gauging how much the patient knows already. Those are actually basic skills in information giving, but applied much more carefully here because you know you're going to give information, and as you give it and the patient understands how difficult it is for them and how emotional they may become, it may be much more difficult for them to hear. And that leads to the next slide about sensitivity. And this is where breaking bad news, if you like, differs from normal information giving, although all information giving can be bad news, in that the sensitivity you have to use while doing this is heightened. But again, all these skills here are the same as the skills of any of all consultations with patients. Pausing, reading the patient's nonverbal cues, allowing the patient to express their thoughts and feelings, specifically eliciting the patient's concerns and checking their understanding. All of these are in fact basic skills, but here applied more sensitively. So I'm going to move on now to another major component in steps 3 and 4, which is explanation of further investigations and staging, which is the second part of stage 3. I'm only going to say here, be careful. We explain further investigations and tests, but what we often do is assume the patient wants to have them done. In fact, it's a negotiation again around what tests might occur, what will happen, the time frame, the access to you meanwhile, and the concept of safety netting. And please don't think that all patients who are in their 80s necessarily want to have further investigations or wish to go through the middle that you wish them to go. The last two components of stage 3 are about explaining the treatment and particularly the role of the multidisciplinary team. Many patients, although you think that the multidisciplinary team is normal, think that they're being referred because their particular case is difficult. In other words, that it's not a normal part of care. And it is worth explaining to patients that this is now normal. It does not mean that their disease is particularly advanced. And the last component of stage 3 is ensuring the interaction and coordination between the specialist team, GP and others. Now, I've sort of hinted at here already that there are several possible people who could be the lead clinician, and the baton is passing. But unless there's really very overt coordination, not just about what you've done, not just about what the disease process is, but also about what people have been told exactly, you can end up with a collusion of anonymity. In other words, no one takes responsibility, which is a very dangerous situation. So communication between all team members, very overtly in a way that actually explains exactly what people have been told and what has been done. It's highly important. So now I'm going to move to stage 4. So the patient's already had further investigations. The multidisciplinary team meeting's already occurred. Where's the patient now? Well, obviously, there's more breaking bad news to be done about staging and prognosis, and I won't go into that further because I've covered that, the basic principles already. Then they're discussing options and enabling shared decision-making. Advanced care planning, which I'll leave till when Peter will probably talk more about that in a little while. And again, the interaction and coordination. So what I'm going to really focus on here is not the breaking bad news, but the treatment options. As the second major plank, I think, is vital for health professionals. And the first thing I'm going to mention is, in discussing treatment options, the very beauty of the multidisciplinary team discussion is also its danger. The reason we put it into practice is because it significantly improves our decision-making process. But the one person who's often absent entirely from that decision-making is the patient. And a decision is made without the patient being there, although some people may be advocating for the patient, without actually hearing what they really think about what they want and how they place quality of life versus quantity of life. And it's not tailored to the individual. So the decision of the multidisciplinary team meeting can come down like the answer, as opposed to what the team thinks is best medically for the patient, which may not be what the patient wants to do, taking into account wider things than quantity of life. So enabling decision-making is what we're talking about here. So, this is planning and shared decision-making. And all I want to say here is that it isn't for everybody, but it is for most people. You need to find out if the patient in front of you wants to share decisions, and 70% of people now do. 90% of people want to know what the options are, even if they don't want to share the decisions. So at this point, what you have to do is share your own thinking, ascertain the level of involvement the patient wishes, offer suggestions and choices rather than directives, but be able to explore management options. And this is a very difficult task. This takes a lot of care and practice to really share decisions where people particularly decide on something the opposite of your offering. It doesn't mean you abandon your expression of clinical preference. Please don't feel that. You do have to care for how you do that and when you express it, preferably towards the end. Shared decision-making is actually a very complex subject, which is worth thinking about if we're ever going to get patients truly involved in deciding actually what options they wish to take themselves. And one of the most important options is not doing anything, or not doing anything curative. So my last slide is simply this. This is a complex travel with the patient, working carefully with the patient, thinking about where they are and what they need, as well as what we feel would be best for them from a medical perspective. Thank you very much.
Thank you, Jonathan. So our next speaker is Associate Professor Peter Martin, who's been involved in communication skills training for more than 20 years. Today, Peter will discuss the palliative care stage and transition to palliative care and some of the communication skills required by clinicians at this stage.
Thanks, Meg. Thanks for inviting me. So I'm just going to talk about this transition in its broadest sense. And the first thing I'm going to say is it's not just about referral to specialist palliative care, but these are, this is a palliative approach, and lots of people do this. So it's when the cancer recurs or progresses, or evidence that it might have progressed or recurred. The evidence is that is more distressing than the initial diagnosis. We're not talking about, we're talking about cancer today, but for non-cancer, this is when they're obviously deteriorating and becoming symptomatic and maximal therapy. I think it's a real particular issue for palliative intent treatment, and there's good evidence to suggest that most people, unfortunately, still leave a consultation not knowing that the treatment is palliative intent. I think that's one of the things I'd really stress about this particular, is that we might understand that language, but we have to make that very explicit to them. I also think that whilst there's huge benefits of lots of the new targeted immunotherapies, I think it has, the flip side is it's allowed us to avoid difficult conversations that they've still got often a progressive disease that we may be keeping in check or even reversing, but often it's still progressing. So I just wanted to be aware of that. So the core constructs are that this often overlaps with bringing bad news. I'm going to say a little bit about that just to add to Jonathan's perspective, that we need to be really confident and competent in how we handle a variety of emotions. You're never quite sure what you're going to get. And this whole aspect of how you share that uncertainty with your patients and their family. Prognostication itself is very complex in how we communicate that risk. And we've already touched on this shared decision-making on the illness framework. So I think one of the things I would just add to that is that ascertaining people's goals and values really helps that conversation. And it can't be overstated that finding out what they're wanting to achieve, what's important to them. How you address hope, particularly when the setting is a bad prognosis, and that acronym is for the complementary and alternative medicines are frequently used, ascertaining what people hope for those and why they're using them, but particularly what they're hoping for is particularly important. So clinicians tell us this is a skilled, difficult task, and our community tell us that we avoid these discussions. That comes out time and again, that nobody really had the conversation with them. And that means that when they leave, the generalization is that most of them are overly optimistic and therefore take on more treatments than if they knew more information. So they end up taking more treatment than if they knew. So I just want to say the world's changing. This is a clip from a plastic surgeon in the United States, and where patients are rating each and every clinician. And if you just look at some of the content there, I'm not going to dwell on it, you can see about how they're approaching them. Did they listen to their concerns? Did they treat them with respect? And in fact, in the States, they're now sometimes is being linked to their payment system. So there's a drive to make us more accountable in how we interact with our patients. So I'm not going to cover all the things in breaking bad news, but I'm going to feed back some of the things that I have witnessed in both teaching and giving a lot of bad news. Now, you may have heard of the SPIKES framework. It's there for your information. I'm really just going to focus on the bit that I see, particularly junior clinicians getting wrong, is that their anxiety means they rush finding out the patient's starting point. They go far too fast because they're nervous about giving the bad news. And if you can get that right, that really sets up. So I think in Jonathan's term, this kind of ask, tell, ask, or getting the right information before you give the information is where a lot of people tend to go wrong. That makes it a lot more difficult. And in the active listening, we've heard about that. It's really hard to do that in a poignant, difficult time for the patient, for us to say less or say nothing. In giving the news, time and again, what I see is people give far too much in complex medical jargon. So saying the really simple truth is often the hardest thing to do, but it's helpful and clear for people. Okay, so those are the main things I want to do. So be considerate of the amount of information and the language, and be comfortable with the emotion you tend to get afterwards, and give them time. So that's just a quick slide to say listening is really important. There's a bit of humor, but I think sometimes give yourself time to get their words right, because often it's when you blurt things out that the words come spilling out wrong and you regret them. So consider not only the words, but how you're going to say them. Slow down, think about your tone. So their emotional reactions, why we find these things hard, we worry that make it worse. Of course, the evidence is if you're skilled in these things, you can really make a very difficult task much easier, much better for them. We have our own emotional reaction, which sometimes helps, makes us feel anxious and not so skilled, and we often want to fix it. I think for the nurses on the audience out there, this is something that nurses tell us they want to do something, but that gets in the way sometimes of listening. And of course, this is not something that we're born with, or even with experience doesn't mean we necessarily get it right. We know what some things are, but not the how. And so this does need to be taught and practiced and learned like everything else. So handling emotions, it's about how you respond as well as what you say. I'll not talk about the thin slicing to say that, but when you ask people, it's your tone and how you go about it as much as what you say. There's this sense of patients realizing if you're comfortable with it, and if you're not comfortable with it, then that adds to their discomfort. Giving time, using pauses, that takes practice. This idea, if you wait, they will actually give you really important information, this notion of hang or wait time. Jonathan's already spent a lot of time talking about being really attentive so you can spot the cues. For me, I've also had a lot of patients that said, this is the first time that anybody's allowed me to tell my story without interrupting me. And often that only takes 3 or 4 minutes, which is a real luxury we can give. Obviously, don't make assumptions about what they're saying means. And I think for me, a way of thinking of that is form a hypothesis of what it might mean and then check it out. Get a good question or a way of checking it. And here's just an acronym, this nurse acronym, to ways you might respond to emotions. To acknowledge it by naming it. Oh, I see you're frustrated, or you look sad. Understand what's making them upset rather than assume. Respect them for where they're at. Obviously, be comfortable with silence. And the issue with empathy is it's not we feel empathy, it's how we convey empathy. When you interview people afterwards, the doctor often feels, or the nurse feels, that they had a lot of empathy, but the patients didn't see it, so you have to be very explicit about what you're actually, that you can see that what's like to be in their shoes in some way. So you can normalize and say, many people have told me at this time this is how they feel. Is that true for you? Not make an assumption, but show that this is, something that happens to a lot of people in their situation. So for me, this is one silly little slide, just to remind you that whilst we're thinking something clearly, they will have lots and lots of things going on in their head that make it very difficult, and we need to give them time to organize their thoughts. You can imagine when you hear catastrophic news like that your head's a pretty busy, scrambled place. So referring to palliative care services, I think the first thing I'll go back to front here is that patients often get distressed in palliative care as mentioned, particularly specialist palliative care. And I would suggest you don't defend it by saying while you're doing it, you acknowledge that it can be frightening, and unpack that and explore it and see what experiences or knowledge they have. So again, it's gathering the right information, and then you can share your thoughts why you think it would be of a good idea for them and their family. And there's the evidence on the left that there are benefits in terms of support, stress, symptoms, etc., and where they can be. And actually, if you ask them about their goals, most of them want to be at home most of the time, and that allows you to make this transition much more attractive for what their agenda is, not just your agenda. So share your experience after you've dealt with their concerns, because it can be frightening for them. Increasingly, there's some interesting evidence that it might even improve their mortality, and that hasn't been replicated in Australia, but has in the States, if you're referred early. So this idea that you're not abandoning them, that they're not going to do worse. In fact, if anything, they may do better, or certainly the same. So I would say that shared decision-making, I think we've covered it, but getting the right information is critical because it will change their decision. The research is pretty clear. If you can give them the right information, it often influences their choices. So don't give them one option you think is the best. Give them all the options and then why you recommend one of them. They still want your recommendations, and give them time to decide. And be really honest and explicit about the benefits and the harms, okay? Most of them still want the recommendation from their doctor or nurse or whoever, but they want to all hear that there are options. So be aware of your own bias and agendas. One of the common things I see is that people really hold on to what they want, okay? So that's this next slide, which is don't cling to a mistake just because you spent a lot of time making it. Okay, sometimes you hold on to something and you really want to drive them in a certain direction, so just be really clear of your own biases. And for things like complementary medicines and alternative medicines, here's this quote, thinking is difficult, that's why most people judge. I wouldn't like to tell you how many of my patients have said they felt judged when they've raised this with their clinicians. So I think it's much more important to say, what are you hoping this will achieve for you? Why do you find this, or what do you find useful about meeting this clinician? Because often they give them time, they talk about their family, and they discuss their goals. It's not so much the treatment necessarily per se. So as we move on, what are my sense of the common pitfalls? Well, we give too much information, and we don't give simple, honest facts. We tend to focus on what we're comfortable, which is the biomedical, the science, the symptoms. We don't ask them what's happening in their lives. So that whole illness perspective of their ideas, their concerns, what they're hoping for, what they're expecting from us, and what's happening in the rest of their life. It's very easy to jump in and offer reassurance before you even know what they're telling you. And as Jonathan's already pointed out, we miss cues, often because we're thinking of our next question, or we're thinking of something else instead of watching what's happening right in front of us. So we don't listen, we interrupt, and just waiting those 3 or 4 or 5 seconds is amazing what information you can get back that is really helpful for you and for them, those awkward silences. And ascertain if they do want to have information, how they want it, with who, and when. Often they'll say, I'm not ready yet, doctor, it might be in a fortnight, and I'd like to bring my sister or my partner or whoever with them. And then there's different ways of giving that prognostic information. I find nowadays most people do not want an average because they feel it's like a death sentence, or they just get stuck in their head. Most want to know that 100 people like you, this is what would happen in the next 6 months, the next year, the next 2 years. That kind of population model. Or to say, if it went really well, it might look like this. If it behaves very aggressively, unfortunately, it might look like that. That gives them both something to hope for, but also the seriousness so they can make their plans. And so lastly, what are the benefits in using all these skills that Jonathan and our colleagues have laid out? Well, for the patients, carers and families, that they adjust better to this incredibly stressful situation in terms of distress, anxiety and depression. They make different decisions, improved decisions, and interestingly, in general, less invasive treatment. And this notion of decision regret, in other words, if I'd known this, I would have done something different. They recall things better, and they trust the relationship they have with you, and of course, and have less symptom burden. And for us, we have a better rapport, more job satisfaction, less complaints, and I think for me the real big one is that they ask for less futile or burdensome treatments, which leaves us with a very difficult sense. And of course, this sense of feeling really burnt out by these really difficult conversations that we don't feel we're adequately trained for. So thank you.
Thank you, Peter. So that brings us to the close of our panel presentations. We're going to move now into the panel discussion, and I'll give our presenters a moment to think about a question. And that question is, looking at the people who've registered for our webinar, we can see that there are quite a number of students and participants who are just starting out in their careers. So if you could think of a key message from your presentation that you would offer those more junior or really thinking about focusing on their communication skills, what will that be? So I'll let our panellists have a think about that question for a moment, and I'll just give some information about how the Q&A will work. We will be turning on the Q&A feature soon. So what will happen with this is that you will soon be able to write down your questions using the Q&A button that you can now see at the top of your screen. Now, I think we do have a slide to show what that button looks like. So once you can find that button, you can switch that on, and then you can type in your questions, and as they come up, we will start to see them. So I'll come back to our panel discussion now. I've got a couple of questions for our panellists, but we will start with a question about suggestions or recommendations or key messages for your for junior staff or those just starting out in healthcare. Have I got a volunteer to go first from our panellists? Peter?
So spending time with others, thinking about this, overall, I would say give yourself some time to get your words right. Say less, and then pause and actually watch and look and hear the answer.
Peter? Jonathan?
That was pretty much what I was going to say. I was going to say slow down, actually, in all aspects. I think one of the dangers when you're particularly giving information is to go fast and not give the patient enough time to really hear what's going on, but also not to stop and allow the patient in. So every time you're either listening to a patient or giving information to a patient, slow down. Will give the patient an opportunity to come in and also to hear.
Thank you, and I think Peter talked about that hang time as part of that. And Deborah?
I'll take a little different tack. I'd suggest if you could get a mentor, if there's someone whose style, who's flourishing in their practice, who a little bit older, wiser maybe, who you can even take the opportunity to ask permission to view interviewing a patient, and then maybe even ask them to watch you. I think the art of reflecting upon ourselves and our practice, being able to see ourselves within our practice, I think we can learn from those experiences as well. So a mentor, I would suggest.
Thanks, Deb, and certainly that idea about having someone provide you with feedback on your communication skills is something that we hear a lot from our communication skills programs. It doesn't happen so much once you're qualified and out of that student training phase. So I have a question for Jonathan, and this is really related to some of the messages that he had for us with regards to the responsibilities in providing communication to patients related to the optimal care pathways. So the optimal care pathways define key communication tasks to be delivered by the lead clinicians, and as Jonathan pointed out, this is often a different person along the way. Can you provide some information or share your thoughts as to, as allied health professionals or nurses, how we might check that the information along the various parts of the journey has been delivered, or what the patient understands?
Well, there's two parts of that, isn't there? There's what actually has been delivered, which is difficult to know, but also what the patient's actually been heard and taken away with. So there are two components. One is really good written records of what the patient has actually been told, transmitted between different health professionals, and very often that's not part of the healthcare record, and increasingly we're seeing attempts to make that happen, so it is passed on. But even if it's been passed on, it isn't necessarily been received or understood, and when you give information to a patient who's actually emotionally in the moment, it's very hard for them to take in information, so they may have got it wrong or they may not have understood. And so the first thing to do, whenever you're with a patient, I think, is to ask them, tell me what you understand, tell me what information you've been given and what you're making of it. And actually to spend some time doing that and listening carefully will give you probably better information than you could otherwise obtain. It may not be because they haven't been told. It may be because that's where they are with it at the moment.
So, Peter, you talked a little bit about goals and values and their importance to patient-centred care. I wonder if you can talk a little bit about how to raise these discussions around goals of care.
So you're right, the challenge might be how to get a question that allows people to articulate that and explain what, the reasoning for your asking or the rationale. So often you would say something like, it would really help us make sure we get the best treatment for you if I understand what's important to you, what is important in your life, what's coming up, and then we can see if that, gives us a different direction or helps our choices. So I think it's about explaining why it's important and the rationale, and then giving them permission to tell us what's important.
Thanks, Peter. We've got a question that's come in from Julie that we're going to answer now, and that really relates to working in a GP practice and the idea about the communication between GP practices and patients once they are on a cancer journey. Have you got any practical suggestions, or does the rest of the panel have any practical suggestions as to how to facilitate this communication between the two different areas of the health service?
I'll take that as the practicing GP in the room. It is really, really tricky. You do feel that you give your patients over to the hospital system, and maybe you might get the odd test or hear something from a relative. So it does feel that you are left out of the loop. I think there is really a move to overcome this, and Jonathan's talked about the multidisciplinary teams, which should include general practice in their care. I think this is still a work in progress. I do encourage my patients to come back and see me through treatment. I try and arrange for them to have a GP management plan so that they can actually get some either dietitian advice or physiotherapy. They can come and see me and do a mental health care plan. I'm certainly involving psychologists who have an interest in managing patients with really serious conditions and challenging diagnoses and terminal illness, so that we can all, as a team in general practice, support our patients. But I think inviting them back too, or the other thing I've started to do is to drop a few lines to them every now and again to just say, I'm thinking of you, is there something I can do for you? So technology, I'm hoping, will assist us in being able to bridge that gap, but it remains a big problem for general practice.
Okay, thank you. Are there any other reflections from the panel on that particular issue, that communication between health services?
I think one of the things to do is empower your patients. I give every patient I see any letters about them to them. They hold them dearly, and they can travel around with them and give them to the various people that they may come in contact with. So even if that's not the particular bit of information, it does often help just facilitate the discussion. So I think, you know, changing the whole thing for them to be the custodian of some of their own information.
Okay, thank you, Peter. We do have a question from Charlie, and Charlie's question is, should we teach broad skills or focus on things that we find that doctors really struggle with? And I wonder if there's anyone in the panel that would like to answer that question. Jonathan.
Thank you, Charlie. I think that's a really excellent question, because it sort of depends on how you approach the problems. And I'm going to say that you must, if you like, when we're looking at teaching, thinking and helping people learn, is think from their perspective. What are they struggling with? What are the difficult issues of their world that really they want answering and they want help with? And what I was trying to say in my talk was, they often, or almost always, boil down to underlying core skills. But if you just approach it by going to people and saying, here are the underlying core skills of your practice, that tends to not get people really to be engaged. What really gets people engaged is thinking about the problems they face in their really difficult day-to-day world. So start with where the learner is at, or the person is at, and then, of course, what will come out of that is underlying core skills that can help them. And as an example for that, recently I was working with somebody who was very senior and talking about breaking bad news in a very difficult situation with anger. I wanted to work on that. And the skill that came out underlying was the ability, when being faced with someone who was angry and asking lots of very difficult questions, just to stay quiet and not have to answer every question cognitively, but just be with the patient. And the difficulty was just actually being able to stay silent for a few seconds longer than we're normally comfortable with. And that was a great learning lesson, which solved both the difficult situation, but was a core skill. So I think it is going from one to the other, if you like.
Okay, thanks, Jonathan. This is an interesting question that's come from Spiri, and the question is, to the panel, what are your thoughts on the idea that health professionals' communication skills competency should be assessed on a regular basis, much in the same way that other critical skills are assessed? And I think there's that idea that I touched on, is that often after you finish your training, clinical communication skills aren't then assessed. So is there any thoughts from the panel on that?
I'll start off. I think one of the first things is actually having some training to be able to go to, and that there's a real deficit, you know, in places, depending on what your profession is, what level of seniority are, and something that's evidence-based. So I think if people identify that it's a core skill and they want to improve their work on their professional development, it's about having the ability to go and do that. So that's one issue. I'm not sure about this idea of this kind of, being a summative assessment that you have to get signed off, but I do think if there's more emphasis put on how important that that the organisation or your practice or whatever it is thinks about this, that would be a better way to go. I'm not sure about a kind of hurdle approach. That might worry me some more.
I think Deb's got some reflections that she'd like to add to that question.
And I would agree with Peter too. I don't think necessarily that competency is the way to go, but I think maybe broadening our actual practice, and I'm speaking from general practice, we do a lot in isolation by ourselves. We don't actually reflect upon our colleagues. We don't actually see them at work. We don't see what their styles are. Recently we did, with my senior colleague, we did a family interview around a woman with Parkinson's disease and dementia who really wanted to talk about her options in terms of being able to end her life at her time of choice. And so it was a really difficult conversation with the whole family present, but we actually got to see how each of us performed within a very difficult conversation with multiple players in the room, and how we actually managed to find a plan that actually suited both our patient and their family. So that actually was a good exercise for us.
So I'll just add quickly, interestingly, the College of Physicians got a survey where 90% of clinicians felt that this training should be mandated. Now, I think that's different in competency. In other words, they want to be encouraged to have this training, which I think is different. So, you know, how often do clinicians say, please mandate training? Very interesting.
So I'll bring up my favourite quotation of all time, which is, you don't fatten pigs just by weighing them, which is an American expression, which basically means if you just assess people and don't provide them with education, it's not a particularly helpful model. Having said that, if you are going to assess people on other modalities, so if you're talking about registrars or whatever they're called, advanced trainees, and they are being assessed on other aspects of their practical clinical skills or whatever other, or their knowledge, then not assessing them on their communication gives a strong message that it's not important. And so I am in favour of mandatory training in communication skills at all training levels. What we do at CME, continuing medical education, is much more difficult because we're not actually assessing most people's continuing practical skills either. And I'm not greatly in favour of producing simple annual assessments in that way. But I am very much strongly in favour, as we have now for most in the UK, for every Royal College exam and for every medical student, that they have to pass communication training, because otherwise it does look as if we don't value it.
Perfect. Thanks, Jonathan. So we've got time for one more question before we bring the webinar to a close. It's been a very valuable evening and we've covered quite a lot of content tonight. And this question is from Michelle, and it relates to something that we hear a lot of. So we concentrate a lot on communication between the clinician and the patient, but this doesn't happen in isolation. So the question is, I find it really challenging to keep dominant family members from overtaking the consultation. How do I keep my focus on the patient? And I'd like to throw this open to the panel. Peter?
So I do family meetings as a core part of my business a lot. I think one of the things is, in terms of signposting and sharing agenda up front, I will say, we've got this amount of time. I'm going to go around each and every member of the family, and each and every member will get a chance to ask what their major questions are, and I will respond to all of them. I think if you do that up front, then it's much more difficult for one person to be dominant. And I would say, thank you, Meg, for your contribution. Now we're going to move on to the next person, so that you kind of, without escalating kind of a sense of tension, particularly in a very emotive time often for the family member. So that's just one of many techniques, but it's certainly very common in practice and can be quite challenging to try and unpack it once it's already happened. So I think setting out, sharing the agenda and being explicit about the structure right at the start really helps.
So, Peter, when you're talking about those kinds of consultations, how do you deal with issues around different information preferences for different family members?
Well, so that's a good question. So again, at the start, I'd say I'd like you to say what you would like to know, and maybe map out, and also give them permission to say if there's a bit of this consultation you don't want to be part of, we can maybe kind of do it in different parts. That's particularly relevant for often for giving prognosis. Some people will find it very useful and important to know, and some people say, no, I'm not ready to hear it. I think that's really important, how you invite them to say what their preferences are again at the start.
Jonathan?
It's such a difficult problem. I'm really glad that it's been brought up because it happens all over. I must say, if you imagine the GP's position, I mean, in my world where we would do a lot of home visits for people with palliative care situations, it's very often the case you never see the patient by themselves. And so you never get a chance to speak to the patient without the significant other there who, even if they're not saying anything, is influencing what the patient is wanting to talk to you about. And there are models for dealing with that. And the one I used to use, as I'm retired now, was very much, if I sensed this was happening, was to say that it's my normal practice to speak to both the patient themselves and the relative themselves, and then together, which is time-consuming. But otherwise, there's this terrible worry you're not really hearing what's important to the patient, as the questionnaire really says.
Okay, fantastic. Well, at this time, I'd like to close the webinar. As I mentioned at the start of the session, we will be looking through the questions that have come in both in the pre-registration and during the Q&A session. And for any common themes in the questions, we'll be providing responses to these from the panel members as part of the resources that we make available for the webinar. At this time, though, I'd just like to remind everybody about that time and that additional support that can be provided by the Cancer Council Victoria's 13 11 20 number, and encouraging patients waiting for specialist appointments to call our cancer nurses for additional practical and emotional support. So our cancer information and support line is staffed by experienced cancer nurses, and it's something that GPs, practice nurses and specialists can offer to their patients between appointments with them or while they're waiting for a diagnosis or test results. The nurses are not time limited, so they can spend time with patients going through their questions and concerns, and also provide help to health professionals by providing evidence-based information and resources to support the provision of optimal cancer care. So calls are answered by the cancer nurses between 9 and 5 Monday to Friday, and there's also an emailer cancer nurse line as well. So I'd like to thank everybody for their participation tonight, and you will hear from us within the next week with the webinar recording and resources from this evening's session. Thank you.